Dun dun dun.
Dun dun dun. Here we are.
Hello, how are you doing today?
I am doing good. On our regular Friday, just trying to consolidate everything and get through to the weekend.
Yeah, I think a theme that we have as the consulting psychologist, we like to help people channel their inner Friday no matter what day of the week they're
Yes,
coming to us from.
absolutely. In our hearts, it can be Friday at any time.
Yeah. And maybe, the past episode of compartmentalization, maybe this fits with that your Friday can happen anytime. Just allow your brain to go there.
I love that. It actually makes me think about kind of a saying in addiction treatment where I did my master's internship, and it was you can restart your 24 hours at any time,
Mm.
right? And so it's not just when you wake up the next morning or when you go to bed that night. It's like, okay, it's 10 a.m. and I had a weird morning. I'm gonna restart my 24 hours right now. And I love that idea because it gives people power over decisions that they may make that don't keep them focused on health, well-being, sobriety, etc.
Yeah, love it. Well, I'm excited about what we're going to talk about today. Do you want me to share what our focus will be?
Absolutely.
We are going to be talking about how to track therapeutic progress or lack thereof, potentially in private practice settings or outpatient context, and maybe some just practical strategies that you could implement, um, how you could implement maybe measurement effectively in your practice.
Such a great topic. One of the things that I think probably makes us a good match as uh, a consultation group together is that we both value outcome tracking
Mm-hmm.
and, not just how to do it, but just doing it at all. And so I wonder if you would be willing to share a little bit more just about what it is before we talk about maybe the ways that we implement that in our practice.
Yeah, well, I love a chart, and give me a graph, and I'm a happy camper. And I think, early in training too, working in different settings and um, noticing how, tracking progress was a part of, training and being able to help a client see like this is the level of depression that you're experiencing, or this is the level of distress that you're experiencing, or um, having more of a tangible visual for somebody to know what their experience or symptoms are like fit really well with me, and it gives you something to hold on to as you go talk to the client. And I think as an training a therapist in training, that's really important. But going into private practice, I knew that I wanted to have some type of objective measure, some type of measure that wasn't based only purely on how am I seeing the client's progress or how am I seeing the client's symptoms, but how does my client perceive their experience or their distress?
Absolutely. I grin just because I remember early on, Dr. Marshall Bewley loved a stat. He loved some data, a visual even better. So for you to connect with how meaningful that is for you is just taking me back to origins of our story. So don't mind me there. But yeah, I think the way that you said, hey, this is your level of depression, it can be both putting a picture or a statistic or an objective understanding of it, but I think it also creates a space to say, is that congruent with you? Is that how you see it? Or does this feel like it adequately represents your experience? Or does it underestimate or overrepresent it? Right? When there's normative data, we can say this score is similar to what we might see in an inpatient setting, and here we are in an outpatient setting. What do you make of that?
Mm-hmm.
Um,
Yeah.
right? Like it provides so much more conversation around calibrating a common language, calibrating an accurate perception and it being a way to look at how things are changing beyond self-report. So, I'm with you on all of that. And even if, somebody might have a tendency to report really high, any change is going to be meaningful, even if they may have a tendency to over-report symptoms, right? Based on our experience with them in session or how they report their depression or symptoms versus how they talk about it might be incongruent. But either way, it still gives us a visual. If it isn't going down, if it goes further up, if it kind of has peaks and valleys. So I definitely agree with the way that it provides another way to talk about their experience and how therapy is going.
Yeah. Well, there is some findings that show that routine outcome measuring or monitoring and routine feedback improves, outcomes. And there was one meta-analysis that showed that when therapy includes systematic monitoring of a client's progress through measures, outcomes are better compared to no such tracking. So I think that's exciting to see that, having that continual discussion or having that aspect of we're going to measure your progress or we're going to measure your symptoms as we move forward also kind of helps the client know, like, okay, we're going to be able to, really evaluate, am I making progress or not, versus if that's not part of the conversation, it can sort of be this like abyss of like, where are we going?
Yeah, that essence of aimlessness.
Mm-hmm.
I think for both parties, for the client, but as well as the therapist at times.
Yeah.
Why? I mean, I think we just kind of talked through it reduces aimlessness on all sides, but why else do you think outcome tracking might improve therapeutic outcomes in a statistical way?
I think, well, I know for me, like sometimes one of the measures that I use, looks at substance use, looks at risk factors. And sometimes I'll have a client where at intake, they deny substance use or they deny a history of risk factors. But the measure then, assessing that, sometimes they'll start to answer sometimes or occasionally to questions that if I hadn't had that measure to give me that data, I don't know if it would always be on my radar to still be monitoring. So I
Mm-hmm.
think it also helps add a little bit more accountability to, we're going to be talking about the difficult things as well, or the things that maybe are a little bit more stigmatized or we have shame or secrecy around.
Yeah. So that it's like kind of setting a precedent for there's no holds barred for what we will talk about in here.
Mm-hmm.
And, it doesn't mean that a client may still not underreport something, but even still, I think from a psychologist perspective, we can be really grounded in, but we're asking about it in multiple ways, right? So we might ask about it in our intake paperwork. We might talk about it in our intake session. And, regardless of whether it's relevant or not, we're asking about it in an outcome assessment in some meaningful way. Yeah.
Yeah.
I am with you on all of that. And again, I think we share a value for outcome tracking in this way. I think the thoughts occurring to me in the moment, especially in hearing that there is some research that supports improvement in outcomes, is what a part of that might be treatment effect or impression management. Where does a client report lower symptoms or something to please a therapist in some way, or because they have some kind of self talk or self judgment even about the expectation to make progress?
Mm.
I don't know, I don't know if you know anything about that or what your thoughts are just about the potential risk of outcome tracking having an impression management aspect.
Yeah, well, I love that question or that piece. I use a measure that I pay for, that's not part of my electronic health record. It's more of an external measure. And one of the things I like about it is that it gives me a feedback message that will say, this person's like making unusually rapid progress, or this person's scores are, to be expected in someone who's not seeking treatment. So especially if I start with a client and they fill out my measure and they give me really low scores, maybe in that positive impression place, I'll bring that into the room. Like, you're telling me that you're wanting to work on these struggles, and this one measure that we did have you fill out shows that your distress seems to be kind of non-existent. And help me understand maybe how that fits for you or doesn't fit for you. I think that is one way that it can get at, maybe there's that positive impression, whether that's the first appointment or moving forward. I think that the thing I like about measures is I'll also look at the therapeutic alliance. And I think verbally it's easier for people to say, oh, things are great. Thank you, doctor. Thank you, therapist.
I love it. Yeah.
But if they fill out a survey, I've noticed there's a little bit more honesty or ability to say, this part I'm struggling with, or even more interpersonally, some of the questions that I have, the therapeutic alliance kind of look at, like, how do they perceive me, liking them or seeming excited to work with them. And sometimes people answer those questions in what would appear to be a negative way, but then when I assess it, it's more around, well, it felt weird to say, yes, you seem excited to work with me, or like, maybe you don't feel that way about me. So it creates a great conversation.
Yeah. Or it allows space for that moment where, you seemed distracted that day, or you seemed frustrated around a certain conversation, which is twofold, right? I think it creates space for interpersonal dynamics to be brought forward. I think it's also about being really like being very introspective as the psychologist in this space, to say, I'm not excited to see them. What does that mean? Or I am. What does that mean? Or maybe because our rapport is typically so good, I allow myself to not maybe work in the same way that I might with someone else who I have, and then that's not appropriate either, because we need to be present consistently with everybody. So that has come up before too, where I saw that and I was like, they're not wrong. I was distracted that day, or I remember that day vividly, and I left that session feeling like it wasn't my best work. And they felt that too. So I need to really be mindful. And so making meaning from that, I think, is an important part of staying ethical, of staying in tune, and for ultimately being effective.
Yeah. Well, maybe you can share too, like what led you to have a measure be part of your private practice?
But absolutely. So, definitely in training, I was trained on using an outcome assessment for measuring treatment progress. I want to say it was like every 2 or 3 sessions, and taken in every 2 or 3 sessions. And then, we would present about it, and we would show the graph of those scores in our practicum assessment course or practicum class. And so there was a lot of training about evidence-based care and how outcome measures are a part of that. And so that was certainly a part of my training. And then after that, I went into a more kind of agency setting where there was also outcome measures integrated into the EHR, the electronic health record system that we used. And that was just always meaningful data, right? And so when I went into private practice, I knew, it's twofold. Going into private practice is a lot anyway. And so I will be honest in that outcome measures wasn't part of my initial process, but it was always on my radar of how could I incorporate that in a meaningful way in this setting. And then I would be completely honest with you, the conference, and there was a session on outcome measures in private practice. And I was like, ding. So I attended that session, and I don't remember what the measures were, but I remembered having that reignited in me about something that was just really important for the process. So I remember leaving that conference and searching for the measure that I was trained on in graduate school to see if it was at all accessible in this context, and it was. And so that's how, and then I initially adopted that and incorporated that into my practice. And so that's how I did that. And that was early. I want to say, probably within 3 years of being in private practice that I integrated that in.
That's awesome. Well, and I think that's also like the gradual process. It doesn't have to be something that you hit the ground running with. Great if you do, but it may be something that people listen or that are listening can add to their practice as they are moving into their practice or building their practice.
Absolutely. It's multifold, right? Let's not let complacency become avoidance or like seeing it as less important, but it's it feels very authentic to be incorporating that in for sure.
Yeah.
I want to speak to this too. We have an ethical obligation in our care to discuss our clinical impressions with clients, right? Whether it's doing a formal assessment and having an obligation to deliver assessment results, being able to provide a treatment plan, and being able to provide an assessment of progress. Now, obviously, just because we say it doesn't mean it's the lived experience of the person on the other side of the room or the screen. But when I think about it that way, I think about it also about the ways that outcome measures can both show clients' progress, maybe even an interpretation of that could be our own efficacy of treating that case or that symptom set or that fit of a client. But it can also be about identifying when it isn't working or something isn't changing and why is that. And so we talk about progress and efficacy, but I think it's also about being able to identify when it isn't working, which is just as important. And to your point earlier, maybe more difficult to identify when clients in a space are more likely. It is difficult for anybody to provide constructive feedback to someone's face, right? And there are lots of writings and books and strategies for navigating that, but outcome measures are a way to do that as well. And so I think we owe it to clients and ourselves for our continuing lifelong learning process to be able to get that feedback in various ways where people might have more emotional access to provide it.
I love that. Well, and I feel like you're bringing up, I'm sitting here thinking like the therapist really has to be willing to be humble, to listen to feedback. And, why did you give me a disagree on this question? Or I
Right.
thought we were, you don't want to be a clingy therapist. You don't want to be too defensive of a therapist. I think if you're going to seek that kind of feedback from measures, being really, open and willing to hear, you may be having an impact that's impacting the progress of
A
treatment.
negative impact. Yeah, absolutely. A branch of that tree, I will say, I do think that we also bear with me with language to you and our listeners, because we are consulting psychologists as well. We are consulting in this moment. That I think we also outcome measures can also help us prove something. It can be proving to the client that maybe they're doing better than they acknowledge or worse. It can also help us prove is a challenging word, so bear with me, but it can also help create a clinical story for external payers, right? From a managed care standpoint, the burden of medical necessity is on the clinician. And outcome measures can help support that story as we bill insurances or a third party payer of some sort, that we can say this person is illustrating or demonstrating symptomology that is consistent with X, Y, and Z levels of distress or X, Y, and Z populations. And I think that sometimes the managed care side of it is certainly, it's again, the burden of responsibility is on the clinician for proving medical necessity, but also some of the most rewarding opportunities I have are with clients who are prone to underreporting. And we have that conversation of, like you said earlier, there's a discrepancy in what you're reporting and what this shows. What do you think that's about? And then I say, okay, well, now that we've had this conversation, I'm going to send it to you again. And I want you to take it again based on, you don't have to hide anything from you or me. You don't have to, deny this for yourself. This helps us know where we need to go. And then when if that score does become more in alignment with their self-report of symptoms, talking through what it's like to do that and how that can be such a profound exposure experience for people, allowing themselves to acknowledge their challenge. So, I think about it from that way too, proving to managed care perhaps, but also proving to a client that their experience matters.
Yeah, definitely. I love that. Well, and yeah, it's data for you, data for the client, data for the story that you're helping shape in terms of just their treatment. And I think I have a similar experience where sometimes clients fill out and, I met my measure and they're like, wow, I didn't know that my symptoms were that bad or that high. And,
Or I didn't know
normalizing.
that was a symptom. When I
Yeah.
was reading, like sometimes my stomach feels upset. I didn't know that. I thought that was just because I had like a queasy belly. Well,
Yeah.
maybe you do, but let's notice when that queasy belly gets activated.
Hmm.
So sorry to interrupt you.
No, yeah. And validating, like, yes, thank you for sharing. And this is a great reason why you starting treatment is so important, and like not pathologizing them being so truthful.
Hmm.
Um, I've also found those to the point of sometimes where the positive management, impression management is happening, where a client so underreports their symptoms that from an external perspective, it's like now there's a little bit of a bind of like, you're telling me that you're in distress, but then you're reporting very low distress. And how will that, impact managed care issues? And
Hmm.
I think to your point, I really like how you said that, like talking about that with the client that then allows them to maybe consider taking it again from that perspective of, you know, allowing themselves to be as honest as they need to be.
Hmm. Hmm.
And if the client fills it out again and it's still really low, then I might be willing to say, okay, well, potentially treatment's going to be pretty brief.
Treatment is
Like,
brief, or it's time to reduce our treatment frequency,
yeah,
right? Maybe it's going from a weekly to a biweekly or a biweekly to a monthly appointment.
yeah,
And what do you have you introduced it in that way before?
yeah. I'll be like, look, from a graph perspective, this is a lovely decline slope that
Mhm.
we're wanting, or that is ideal. And it doesn't always happen, but with that, I think, based off the progress that you're making, it all also might indicate that we need to reduce treatment frequency. And that's not to punish you for your progress, but to help you see, hey, you're making enough progress that I think we can not meet as much, and see how can you maintain that progress without us meeting so frequently. So
Hmm.
trying to kind of frame it in that way, but I absolutely think about it from that perspective of, if their scores continue to reduce in distress levels, then I need to listen to that progress as it relates to kind of medical necessity issues.
Yeah. Yeah. I ask in part because I think that there are situations where that conversation happens really naturally, right? With or without a chart. But even to say, okay, what you're reporting is exactly what you were wanting. And what does that mean for us now? And they're like, yeah, I don't want to not meet at all, but what if we were to kind of, can we meet less often? Absolutely. It's not that I don't want to see you. It's that I want to see you meet your goals and feel able to have this conversation. So if you want to, what kind of a frequency feels right for you? And they say like, let's try once a month or let's go every 8 weeks. Yeah, I got you. And so, I think that those can really be really organic things with and without outcome measures, but outcome measures just support it and it helps them get there even to see their own chart. And then I think that there are other things, right? Where maybe folks have some attachment wounds, and from an object relations place, maybe they're attributing their progress to the therapist or the therapist space and not to themselves. And so there have been times when I have this conversation of, oh my gosh, yay, look at you. Of course, like, is that accurate? Great.
Yeah.
What happens is they're like, but I don't want to meet you any less frequently. And I'm like, okay, let's talk about that. Like, how come, or what's that about? And so, I do think that sometimes people may need the next part of that process is transitioning maybe the ownership of that progress back to them and not to the therapist or the therapist space, or kind of recognize it sounds like you feel like your progress and ability to maintain this is hinged on me in some way or us in some way. And being able to kind of help them tease that apart so that they are internalizing it versus externalizing it.
A lovely therapeutic conversation, and just, I mean, that I can imagine that goes really far in terms of just having a healthy examination of the therapeutic relationship too.
Mm-hmm.
I think this is exciting about the measures, is that it provides so much grist for the mill, so to speak, in terms of conversation and process. And I want to talk a little bit more too about just the logistics.
Sure.
And then we're going to talk about maybe the bad and the ugly side of implementing these measures. There's a few things I want to just bring in, but I wonder, how do you maybe choose the measure that you use? Like, I know it can feel overwhelming maybe for listeners to think about, like, where do I even go for this, or where do I start?
Yeah. So in the origin story of outcome measures in my practice and currently, there is a standardized process that we have that is really broad, meaning that the measures that we use to explore, baseline symptoms and then tracking is a measure that is broad. It looks at depression, anxiety, stress, overall life distress, and and a therapeutic alliance assessment of sorts. And so, obviously one won't be able to fill that out, but that'll be included after that. And so, from a system standpoint or a standardization aspect, we use the same stuff with everybody. And so, and that's, again, trying to create some standardization. There are so many good measures out there, though, and ways to hone in on a specific presentation. So when there is a specific measure for a specific syndrome, like OCD, for example, I do use very specific OCD measures by client. And we may incorporate that in session as a therapeutic assessment where I do it verbally and we talk through what that means to them at time one or subsequent times. And then there are also ways to do that where it's a self-report measure on their own. So part of this is the responsibility of us as psychologists and therapists to make sure that we're staying aware of what's available and that it's a psychometrically sound instrument, unless it's more about gathering qualitative data about the client's experience. But, so having these conversations, staying on top of it, making or seeking consultation from the consulting psychologist or from other colleagues in your life, where you may be like, hey, what do you use to track progress with maybe disordered eating or OCD or even grief and the experience of impairment related to those kinds of things? So I would say we do it in a standardized way, and then we have some options that are fairly accessible, kind of presentation by presentation. There's a really good trauma measure. There are some things that are really specific to anxiety and depression that can hone in on those symptoms. So I don't know if that answers your question.
Yeah, for sure. And, I think we've talked about this, but sometimes your electronic health record has options. There's external measures. And for instance, I use an external measure that also, when I do group therapy, there's one specific for group therapy, and is the person ready for a group? And then the assessments that kind of measure how is their progress within the group space.
Mm-hmm.
And then I have like a relationship one that if I use with couples, or
Mm-hmm.
sometimes if a person's dealing more with relationship issues, I'll send them that measure. So I like that too, that I do send the more general broad one, but
Mm-hmm.
we'll get specific when necessary.
Mm-hmm. Absolutely. Staying aware of the research and just keeping the conversation going in your own career around what measures are available is imperative. And I will also say that depending on where somebody is in their practice, they may need to rely on free measures, things that are put out there that are psychometrically validated and that are available from the publisher, or, available online. So, for example, the World Health Organization has a lot of different free measures that people have really, maybe, I don't know if this is the right term, but donated their science and research to the greater good for people to do this work. That's how important it is that there's a lot of free stuff out there. I have paid for measures before, ones that I really liked, ones that I was familiar with that I thought were robust. And it's interesting that you bring this conversation up. We're actually changing our system a little bit, if this is a good time to talk through that.
Mhm.
That we've been using a measure that has great empirical validation and that we've paid licensing for years and years, but it is external to our system, which means that it's another portal that all clinicians need to log into to look at scores and be able to look at those charts. And then it's an external system that the office manager has to manage in terms of sending measures and documenting that they've been completed and in their chart and so forth. And so we've gotten to a place where that just is no longer, it's not as much the cost of the licensing as it is the administrative load that it entails. And, so for our system and the way that we're organized, that's just no longer as functional for us. And it was a really big and hard decision to make the decision to switch to something else that is more integrated in our EHR, and I don't know how that'll go. I'm hopeful. I'm really excited about the measures that were available to use that are already, I think that they're free in the world, but they're also already integrated. So there's no extra cost. So it reduces the licensing costs in that way. And because it's integrated into one login system, it'll increase ease of use for clinicians, but also reduce the administrative time required to send it and make sure clients are doing it and so forth.
Yeah.
So, again, was really bummed to move on, but one of those really tough business decisions that was being honest about what is meaningful anymore. And if we're doing it just to do it and paying for it just to pay for it, and nobody's using it the way that we're having this conversation in the spirit of what it's intended to be,
Mhm.
then we're just checking a box. But I'm really hoping that this will maintain and sustain clinicians' value for using outcome measures in the practice.
Yeah. Yeah, this kind of gets into like the good, the bad, the ugly. The bad and the ugly side of measures, I do feel like is there is an administrative burden to it.
Mm-hmm.
And I don't know about you, but regardless of the setting that I've been in, including my current practice, a lot of clients don't like the assessment or don't like
Yeah,
the measure. And even if I show them the graph or show them their progress, or, you know, it's one more thing for them to fill out too.
yeah,
Um, and so, but I think, to bridge that, I think a big part of it is how you set it up in your practice to
yeah.
talk about it. If you treat it as like, oh, yeah, thanks for filling that out, and don't bring it up, then you're kind of showing that it's not really that important. So I know I talk about it in my policies and procedure. I talk about it the first time I meet them. I, you know, talk about like, we're going to keep doing this regularly. And
Mm-hmm.
if you don't like that, we can talk about that. But
Mm-hmm.
I think, it can be a burden for the clinician, for the client, and you've got to figure out a way to kind of implement it for you. So it's exciting to hear how y'all are going to kind of do that in that way that works best for you. As a one person show, what I typically do is I'll send them, my goal is to have people fill it out once a month.
Mm-hmm.
And so like earlier before we met today, I emailed all my clients for next week on the client portal that I have, and send them their unique links to send, to complete their assessment.
Mm-hmm.
So I try to do it at a week at a time.
Mm-hmm.
That works best for me versus like day by day.
Sure.
But what that means is maybe my clients next Thursday will be like, oh yeah, I forgot because it's been a week out. So
Right.
sometimes
Yes,
the follow through can be an issue.
absolutely. You make such a good point about the clinician's attitude about the outcome assessment, and reinforcement of it or lack thereof is imperative. And it's just like with homework, right? It's the same thing. If we don't ask about that homework that we talked about last week, we're saying you can disregard these things I say, which in a lot of ways is undermining your clinical and therapeutic power. Um, and I think that could be therapeutic power could be another conversation and another day. And the same is true here. And so one of the ways that I try to increase completion of those things is related to if I realize I haven't done it, especially for a virtual session, I'll send them a quick note in the portal that just says, hey, look forward to meeting you with you soon. Please be sure to complete those measures that were sent to you, recently. And if you need session time to complete those, I'll begin session when scores come through on my end. Well,
Yeah.
when people are like, I don't want to spend session time in that way, usually we get into a different habit of them completing it. And that's, I think it's harder sometimes with existing clients who may have existed before we implemented these kinds of things. But if we start it from the get-go, people know what to expect. And that may also be, I don't know if this is good, bad, and ugly, but maybe so. Maybe this is another indicator about goodness of fit with you as a psychologist, or with our practice and the clinicians and the way we operate. We value this, and if this isn't a value of yours and it's not something that you want to do, maybe that just means that we're not a good fit for you as an agency, and that's okay. In the same way that keeping a credit card on in your portal securely, using a portal for messaging because it's secure, using a portal in general, which I've gotten feedback about that people don't always love, is that this is just a condition of receiving services from our practice. And it's okay that you don't like it, and it's okay if you opt out. And opting out means that you are opting out of receiving services from us. And so I guess I that's also, I think, therapeutic power, that we get to have that standard. And it doesn't have to be an attitude about it. It's just sort of like, I totally get it. And keeping a credit card on file, completing outcome measures is a standard of mental health care practice. And it's how we value making sure that we're providing the highest quality of care to you. And if you're wanting to do, that's okay, but that just means that we're not the best fit. So again, it's how we talk about it.
Yeah. I love that. Well, and the piece around, we'll start session once it's complete. Not that has to be threatening, but working at bigger sites, like that's what happens. The front office takes care of that, and then your session may start 10 or 15 minutes later. I like to do it ahead of time to not use that time, but in situations where a client just will not complete it, I think about it from a compliance place, but I have an iPad in my office that I will give them in the waiting room if they're in person, and we will start once they're complete. So, but I think part of you have to kind of integrate it into your workflow, your session workflow in a sense. So when a client completes it, like this coming week, the first thing I'll do is I'll start with the assessments, and I'll pull up the visual. If it's a telehealth session or in person, I'll have my iPad and we'll look at it together, and then kind of base conversation off that. So I think if when you integrate a measure into your practice, it's thinking about like when or how do you want to implement it in the conversation. I tend to think that if you do it at the end of session, it can kind of open up a can of worms in a way that you don't have enough time to.
Yeah.
And to your point, it might indicate this isn't as important. It's just a last session comment or processing.
Absolutely. The other thing, I think you've maybe alluded to this, but I'll put it in relation to what we know about some behavioral therapy, and some operant conditioning principles, that we know that from a parenting perspective or a reinforcement perspective, that punishments or reinforcements are kind of most effective when they are kind of timely in relation to the situation, relevant to the situation, consistent to that context. And there's another one that's escaping me right now. But right, all those things are really important. And so this is the same. If I know that they did it yesterday or over the weekend or the day before, that morning, hey, you did that. Let's take a look at it real quick. Not because it's a quick, unimportant thing, but it's like me trying to prioritize. You did it. Let's be timely about looking at it. Let's explore what that means to you. And that way, the content of our session that day may actually be informed by it. It may not be, but it probably will be in some capacity. So that's the way that I see it.
Mm-hmm. I love that. So yeah, the timing and the frequency, I think, would be a thing to consider. Just like how frequent do you want it to be in your practice, and what what's practical there. And I think some, I've worked with people who actually like it to do it every week, and they'll have their link that they can go to, but I don't know if that's practical for everybody. So I think as you maybe add a measure to your practice, consider, maybe playing with a little bit, like how frequent do you see it working for you in your practice?
Yeah. Depending on how, we can look at it by time every month. We can also look at it by sessions, every 2 sessions, every 3 sessions. Like I said, I was trained on doing it, I want to say every 2 or 3 sessions. So it was based on sessions, not time, because some people might be coming in twice a month-ish. Some people might come in monthly. Some people might come in weekly. And so I don't know that there's a right around it, but what we do is sort of, I believe that we do it every 2 to 3 sessions is how I have it written in my practice policies. And so there are some settings that I think we might, but I think some of the settings that we're adjusting to as we recently changed over how we're doing outcome measures, that it might be more time-based. And so in that case, I think that we are going to do monthly. And so, for monthly clients, love you, mean it, you're going to do it every time. And you know what? A lot can happen in a month. You've practiced your skills and and it clicked and you're like, oh my gosh, and we have a decrease in score. If we aren't doing it as frequently, what are we missing? So, going back to that, I think that there's no right answer, but it is about what's meaningful when we think about how we can help clients build efficacy in themselves.
Yeah. And this maybe is a little bit practical focus, but I'm thinking like, if the listener is thinking like, oh, this sounds exciting, I want to add this, but how would I write about it in my notes? Can you share maybe, and I'll talk too, but how do you integrate the results or the measure in your session notes?
Sure. Historically, the results are added as a session note in their chart. And so while that's its own note, in my session note, I have a canned statement that says client and therapist explored recent results of outcome tracking and recently discussed outcome tracking and explored congruence with lived experience, something like that. And so it's just a canned response that I add in there that this was discussed. And because it's already documented in another note, I don't need to document the scores twice. That's how we do it. Now, with our system is changed in that we won't need a separate note to report scores. They're already integrated into the client's chart. And so the canned response will still be added in the notes that those scores are discussed. Therapist and client discussed recent scores of outcome measure and process congruence with lived experience. I think that's exactly what the canned response is.
Okay.
That's how I do it. Again, it isn't going into detail about what was discussed, but it is referencing that it was discussed. Again, the detail is going to be, I think that there's some stylistic things in there. There's no right or wrong, but because we already have it documented, it's my way of not duplicating documentation. If there is a noteworthy response, that's not right. I don't know where that's, kind of like a rejection of those scores, or Typically that is probably going to be discussed a little bit more. Client explored tendencies for underreporting symptoms or overreporting symptoms that contribute to a lack of congruence in understanding their lived experience, or, something like that.
Yeah. Yeah, that's interesting. I mean, that's a little bit different than I do it. I have a data form that for every session, I have a measure section, and if I didn't send it, I'll click. It's a point and click kind of, but no, no measure is administered.
Mm-hmm.
But if they do complete it, I'll kind of point and click, revealed significant reductions, or critical items were discussed or reviewed,
Mm-hmm.
or the therapeutic alliance was discussed. So I think it
Mm-hmm.
also helps me stay accountable to, like, hey, I haven't sent this for 3 or 4 sessions.
Yeah.
Let me resend it to also, not just feel like my note is reloaded and nothing's changed in that measure section.
Yeah, no, that's great. And I do wonder if that might there are some style differences there, but maybe it's also the difference between that's your way of tracking it versus having we have an office manager who does that for all of the clinicians on the team.
Mm,
So,
yeah,
right, like there's a difference there in that's part of your tracking versus that's being done externally. So
yeah,
that makes great sense for somebody who might be in a solo situation and it's their way of not having of just being able to see it as a glance from the previous week to week or session to session.
hmm, yeah,
And there's so much range of how this may look in a practice, from in a practice of 1 to a practice of 6-ish to a practice of 20 or more, right? And all I hope is that anybody in that continuum is doing it at all, right? That's my hope for that's my hope for our field, for evidence-based care. And you heard it here, the consulting psychologists, outcome measures, improve treatment outcomes, and provide an alternative data set for informing care.
yeah,
And that this goes far beyond the session and what is discussed. This is about using that clinical judgment, clinical conceptualization for ensuring that your treatment is evolving with the client. So yeah, I'm happy to consult about this.
To throw it out, just to reinforce what we're saying, there was a study from 2013 by Lambert and Low Coco that showed that approximately 5 to 14% of clients worsen in routine care, and many of those could be flagged earlier if there was monitoring in place. So, the data, the research shows that this is in our interest and the client's interest to really be monitoring symptoms regularly.
I was kind of like wrapping us up, but I think you bring on something so important. Can you say more, just, interpreting that statement? Can you say more about the potential risks of not doing this in terms of worsening client outcomes, not doing outcome measures?
Maybe you can help me to think about what you're thinking, but I think it would be about you're not seeing warning signs or um, risk factors, or you're not noticing distress that might, be non-verbally communicated.
Absolutely. That while the outcome measures are just another data point to incorporate into the clinical work, if we're not collecting it, we may be hearing one thing in session, but a client's lived experience is something different. And, if we might be able to recognize a treatment non-indication or a contraindication for the care that we're providing earlier by collecting these measures to make sure that scores aren't continuing to go up. We know that they normally will go up a little bit more before they come down because we're opening stuff up. And we're maybe doing some exposure of some sort or whatever. But if they don't come back down, we really need to be mindful. And if, again, self-report is one data point, and so is objective report or objective assessment through outcome measures. So we're going to catch that sooner and prevent worsening outcomes by incorporating this into our practice at the outset. Right.
Love
So,
that. Yeah.
yeah.
Well, that's a wrap.
So, yeah, awesome. I think this was a really cool conversation. I always, again, when we consult about anything, as consulting psychologists ourselves, it is affirming. Consultation should do one of a couple things. It should confirm what you're doing. It should maybe give you new ideas for how to improve it. Or it should put on your radar something like, oh, that's probably really something I should be doing and I'm not. And that's not about shame or wagging fingers or anything like that. If somebody isn't doing it, it's more about, have you considered these pieces? And so I believe that affirming or reinforcing consultation is just as valuable as that consultation that opens our eyes to something that we never considered. So I just want to normalize some of that for folks too.
Yeah. Awesome. Well, until next time, we are the Consulting Psychologists, so we will talk to you next time.
Next time. Bye.
All right, bye.